Welcome to our webinar titled, When Does a PNH Clone Have Clinical Significance? Thank you for joining us. My name is Lee Clark, Director of Patient Programs, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you lose connection, please refer to the confirmation email with the Zoom information and that provides a call-in number. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, type in the Q&A window, and when you have finished typing, just hit enter. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert speaker cannot answer any specific questions related to your health care. Our specialist today is Dr. Daria Babushok, who is a physician scientist and assistant professor at the University of Pennsylvania. She earned her medical degree and PhD in cellular and molecular biology from the University of Pennsylvania. She completed her residency in internal medicine at Massachusetts General Hospital, followed by a hematology oncology fellowship and a postdoctoral fellowship in hematopoiesis at the University Hospital of Pennsylvania. Dr. Babushok's research and clinical interests focus on the development of acquired and inherited bone marrow failure, disease progression, and malignant transformation, and improving treatments for patients with bone marrow failure. It's my pleasure to welcome Dr. Babushok. Thank you for joining us today.
Hello, and thank you very much. And it's an honor to be here and to give this webinar. Let me share my slides. Okay, so please let me know Lee and the organizers.
It looks good.
Okay, very good. So today, the goal of my presentation is to discuss the clinical significance of PNH clones. And I have a very long agenda, and I would like to make for all of this information to be practical and relevant to everyone. So today we'll discuss the origins of the name PNH. I'll very briefly review some of the hematology basics about the blood cells and the bone marrow. And then I'll discuss about what causes PNH, what are the PNH cells, how is PNH diagnosed, how do we interpret a test report of PNH results, why is having a PNH clone different from having PNH disease, what other lab tests are needed to evaluate PNH, and then I will focus on some examples. I will have a total of 5 examples in which I will illustrate the difference between having a PNH clone, PNH disease, and how the report helps us to interpret this. So I'll talk about classical hemolytic PNH and also discuss the relationship between PNH and PNH clones in aplastic anemia. And then I will summarize. So that's our agenda for the next, hopefully 30-40 minutes, and then I'll open for questions. So first I'll mention that PNH, of course, stands for Paroxysmal Nocturnal Hemoglobinuria. And so this is a historical term that basically dates back to when patients were presenting with paroxysms, or these intermittent amounts of dark urine, hemoglobinuria, that happen to be darker at night for unclear reasons, but potentially because there's a little bit more concentrated urine. And you can see the picture here. This is, again, a historical photograph of a patient with PNH demonstrating the different color of the urine, the darker urine being closer earlier in the morning or at night, and then the urine would sort of clear out a little bit during the day. But despite the fact that urine is in the name, of course, all of you know that PNH is a blood disease. It is a rare blood disease with the prevalence probably somewhere on the order of about 1 to 2 per million, or perhaps even a little bit more rare. So before I begin, I will just review some of the basics about our blood cells. So while blood is taken from the vein, the blood itself, the stem cells, are located in the bone marrow, which is the soft part inside of our bones. And those stem cells then give rise to different bloodlines. And there are 3 different bloodlines: the white blood cells, and those are our immune system. They come in different varieties. And so the important ones to remember for today's talk are something called neutrophils. So those are our first defenders, and they, for example, if you nick yourself and you have a little bit of bacteria, those would be the cells that come immediately to try to protect us from infection. And then we also have other types of white blood cells, such as monocytes. The second bloodline are our red blood cells. So these are the cells that carry oxygen. The oxygen is bound to a protein called hemoglobin. On our routine blood tests, we often measure white blood cell count, we measure red cells, but we really think about our ability to carry oxygen as hemoglobin concentration. So that is frequently what is reported and what the doctor would focus on the blood tests. And then, of course, if that hemoglobin is low, then we would call that patient anemic. And then when you're anemic, you may have symptoms such as shortness of breath, being very tired, having a racing. Some people may have racing heartbeat, or they may have chest pain. And then the other important term that will be very relevant for later today is called reticulocytes. So reticulocytes are another type of red blood cell. It's essentially a baby blood cell or a very early blood cell. And we can distinguish it by how it looks and a little bit of differences in the size and some of the content of that cell. And so we can tell that this is the cell that just was born and just emerged from our bone marrow. And then finally, the third important blood cell type is platelets. So these are the cells that help us clot. They will not be a focus of this talk today. So what causes PNH? So here is a picture of our bone. So this would be our long leg bone, and we can see inside of that bone, there is a space and there is bone marrow that sits inside. And that's where our stem cells and all of the early progenitors of the blood cells live. And then in the middle of the slide, you see the big circle, and that is just a diagram of a stem cell. And so inside of the stem cell, we have the nucleus where all of the genetic material is located, and we have just a picture of a chromosome. And in that chromosome, there are many genes, and we have, as one of those genes is a gene called PGA. So PGA essentially stands for phosphatidylinositol glycan class A gene, but I will refer to it as PGA. And in our, when in the bone marrow, when we have randomly, we frequently acquire mutations. Sometimes the mutation may just happen by chance in this gene called PGA. So it's something that you're not inheriting from your parent. You cannot pass it on to your children. And it essentially develops during an individual's lifetime. And so that mutation happens to be in the stem cell. And then all of the progenitors of that cell, so anything that that cell produces, for example, red cells or white blood cells or platelets, will also carry that mutation. And so anything that has that mutation that disrupts the gene PGA will be called the PNH stem cell or PNH red blood cell or PNH white blood cell, for example. So what does this gene do, right? So the PGA gene is required for us to form a very important class of cell surface molecules on our cells. And so those molecules are attached, and I have a picture here where you can see sort of mushroom-like structures that I put on the surface of the cell to show this. They're basically a little bit of a sugar and a little bit of a fat molecule stuck together, and that allows these proteins to attach to the membrane of the cell. And so there are many different important proteins that are attached to the cell surface through this GPI molecule, or this type of molecule. And I will refer to them using this technical term that I will not use very much today, but just to give you an idea, they're called GPI anchored proteins. So in the normal cell that has this normal gene, we have all of the normal surface proteins. But in the PNH cell, the gene is broken and these attachments cannot form. And so none of these molecules are there. And why is that important? Well, on red blood cells, these molecules are extremely important for protecting our red blood cells from just breaking up in the blood due to an attachment by this type of immune system protein called complement. And I have it here on the slide as little yellow stars and yellow circles. So we have, our immune systems are quite complicated. And one of the perhaps less well-known forms or important players in the immune system are called complement proteins. So essentially, if, for example, if one is being attacked by bacteria, the first response from our body's immune system would be for these proteins to glob on to bacteria, poke holes in the bacteria, and also both cause the lysis or cause the death of the bacteria, and also help to clear those bacteria out because they're covered by this complement proteins. But of course, you can imagine that how does the complement tell whether this is a foreign invading bacteria or it's something that's normal and healthy like our red blood cells? Well, we have signposts on the red blood cells that essentially are these GPI anchored proteins, these little mushrooms that I have on the cell surface that basically prevent these complement from attaching and attacking the red blood cell. In PNH, we do not have these signposts saying, go away complement, I'm not a pathogen, I'm not a microbe that's trying to attack you. And this complement attaches to the red blood cells and essentially leads to holes being formed and the lysis of the cell. And so the process through which these red blood cells break apart is called hemolysis or lysis. And so the anemia that results is called hemolytic anemia, basically complement-mediated hemolytic anemia. So these proteins glob on, lyse the cells, and then the red blood cells start turning over. So now I will shift gears and talk about the PNH cells and PNH clones and different types of presentations of people who have some amounts of these PNH cells. So shown here is just a graphical example of how many of these PNH cells can be found in different people. So at the very top, we have very, very tiny amounts, the tiniest amounts that we can detect. Let's say 0.005, 0.001% of total cells could be these PNH cells. And that actually can be found in virtually any person off the street. So normal, healthy individuals may have these tiny proportions of PNH cells, but they usually do not cause a problem. They don't expand. And in fact, it's even very, very difficult to detect them. However, anything that is larger, and this threshold is a little bit, it's not well-defined, but certainly over 0.5% or certainly over 1% of these PNH cells is very abnormal. And it's much more likely to be present in people who have some type of bone marrow disease. So in some patients, this may be the classical PNH disease that needs to be treated with some of these new drugs that are called complement inhibitors. while in other patients, we may have much smaller fraction of PNH cells, and in them we can observe, and they essentially do not need to be treated for PNH. So how are these PNH cells detected? So it's a very routine test. It's something that is widely available, and essentially every hematologist is able to order the test. The test does not require a bone marrow biopsy. We would get it from the vein, we would get a blood sample, and then that blood sample goes to the lab, and a test called PNH flow cytometry is run. So this is just a routine machine, and then at the end we would get a report, and some of you may have seen your reports, for example, if you have PNH, and the report has several parts that are very important for your doctor to look at. So usually at the top of the report, it would make a conclusion as to whether PNH clone or PNH cells have been or haven't been detected. And then it discusses some of the other parts of the PNH test result. So how many PNH tests were detected in those neutrophils, also called granulocytes? How many have been detected in red blood cells? And what is, for example, what is the level of sensitivity of the report? So I will go through a few examples. So here, don't focus on this busy slide. I will digest it in a second, but this would be essentially the type of a report that you may be looking at with your doctor. So first, when I look at the report, so this, for example, is a report that says a PNH clone is identified in white blood cells and in red blood cells. And then usually there is some sort of a statement that you may see in the report that gives you the percentages in all of these relevant parts. Then there is a second part of the report that discusses where these clones were found. And before we even get to that, I want to very briefly discuss some of the terms that people frequently throw out when talking about PNH. When we have a population of PNH cells, we frequently call it a PNH clone. So the percent of the cells, whether it's 1%, 100%, would be the size of that clone. And the percentage then refers what fraction of your total red blood cells or of your total white blood cells are PNH cells. So for example, if I have a clone of 99% PNH cells, it means that out of my total blood, all of my blood are these PNH cells, right? And so then the other part that sometimes is confusing, we have a lot of numbers. So for example, on this report, there are many different percentages, right? What is the PNH clone percent? So usually we look at it as the percent of neutrophils. So the neutrophils are that type of white blood cell that I just mentioned. So then if you look at the right side of the slide, I highlighted the things that I would zero in as a hematologist, right? And if you're looking at your report, these would be the types of things to pay attention to. So the two blood cells that you would need to find in the report is the RBC, this is the red blood cell at the top, or neutrophil. So we will look at both of those. Everything else is a little bit less important. So then we focus on red blood cells. And I would say in this report, we have a patient who has 36% of their red cells being PNH cells. Then I go down the report and I find neutrophils. This person has 92% of their total neutrophils are being PNH cells. I then also scan the quality of the report, quality of the test, and I try to determine over what amount of cells is it okay to call a clone. Sometimes there may be artifact or sort of random test abnormality that essentially is not really a PNH cell, it's just sort of noise, right? And so over that percentage at the bottom, where it says the lower limit of 0.01, for example, so we cannot be detecting anything that's less than, let's say, 0.01 as a true test, as a true PNH clone. Okay, so that is sort of technical, and then I'll mention just to contrast that report with another report. So this would be example 2 that I will discuss discuss a little bit in the next few minutes. So in this example, we have somebody who has, again, we're going to zero in on red blood cells. We have 0.07% of red blood cells are PNH, right? So much, much smaller fraction than the previous example. And then if you want to say, well, what is the PNH clone size of this person? We can look at neutrophils and see that it's 0.1%, right? So we have a completely different end of the spectrum. So somebody who has very small number of their total blood cells being PNH cells. So this brings me to the main overview of how to think about your PNH test report. So in order for somebody to have PNH disease and to distinguish it from just detecting a PNH clone, several things have to happen. So first, in order for the person to have a PNH cell, they have this mutation in that gene called PIGA. That mutation then leads to the loss of these important proteins on the cell surface of their red blood cells. So those are called PNH cells. Then it's very important to know what is the number of those PNH cells. So what is the size of the PNH clone? Is it something that's tiny and probably not important or causing any problems, right? So is it 0.1%? Or is it something that is large in number, let's say 99%? If you have a very large clone, you can imagine that those red blood cells are at risk of lysing, of breaking down in the blood. And so that patient who has very large clone would have symptoms from it and would be classified as PNH disease. So I will show this graphic here to just demonstrate, for example, in any given PNH lab, meaning in a hospital that does this flow cytometry assay to detect PNH, and they would be able to go back and evaluate what is the proportion of patients, how many patients have these big clones that we worry about, and how many of the clones that are detected are smaller and probably do not cause many problems. And so you can see this graphic here. So on the x-axis along the horizontal plane, you have a graph of the PNH clone size, where on your left side, you have a proportion of clones. So, and these are plotted in increments of about 10%. So the very bottom, the lowest decile from 0.01 to 10% is the majority of people have very small clones. So that is in pink on the left side. Conversely, we have in blue now on the other side, we have a smaller number of people who have very large clones. And so you have this almost like a bimodal distribution where you have a lot of people who have a lot of very small clones, and then you have another group of people who have larger clones. And so our example one with the very large clone was this classical PNH example, and then example two was the very small clone. So I will discuss these two clinical presentations in a little bit more detail in the next few slides. Right, so the classical PNH are the ones in blue with a mean clone size of probably about 70. So it means that there are some patients who have smaller clones, but the majority have very large clones that cause a problem. And then we also have the patients who have smaller clones. They frequently have a disease called aplastic anemia. And in those patients, the mean clone size is just about 11%. But most patients really have very, very small clones. So I will pause here for a second just to highlight that the PNH clone size is not the only thing that tells us about how active PNH is, and if in that person, the PNH needs to be specifically treated. So there are certain other important points that your doctor will be collecting and that you may see on some of the blood tests that your doctor is ordering. So those would be, of course, complete blood cell count, so CBC with the differential, where we will look at the white blood cell count, the neutrophil count, we'll look at the hemoglobin if the patient is anemic, And then we also look at the platelet count. The second important blood test is the reticulocyte count. So those, remember, those were the baby red blood cells. If the reticulocyte count is high, it means that, and particularly if the person is anemic, you can see that the body is producing a lot of the baby red blood cells, and they're probably being destroyed by PNH through this lysis. And so it means that the disease is quite active. There's a lot of red blood cell turnover. Conversely, if somebody's reticulocyte count is low, then probably they're not producing the red blood cells, and that is why the person may be anemic, right? And then finally, another very important test is called lactate dehydrogenase, or LDH. So that LDH essentially is released when the red blood cells are broken apart. And so that number will be quite high if somebody has the red blood cell breakdown due to PNH. So I will now focus on that example one. So this would be a person who has a lot of PNH cells. So what do patients with PNH present? So the most common symptoms are fatigue. So people are tired. They may be short of breath. They're not able to do activities normally. They cannot exert themselves because of breathing difficulties or racing heartbeat or chest pain. Many people have abdominal pain as they're, in sort of these paroxysms of abdominal pain. They may be going to emergency room and being evaluated. Of course, dark urine is one of the other symptoms. And then highlighted here in red is something that is very common and quite dangerous in PNH, and that is the propensity to form blood clots. So these blood clots can develop spontaneously. They can develop in, for example, in somebody's vein in the leg. Sometimes they break apart and they go to the lung, and so that would be called a pulmonary embolism, or PE. Some patients form strokes, and so these strokes can be due to either different clots, even in the veins or in the arteries of their brain, of their head. And then some patients may have blood clots in sort of other unusual places, for example, in the veins, in the abdomen, and some of them may cause even liver failure or a lot of problems. So this is really dangerous. And before the advent of these new life-saving treatments for PNH, this was really the main cause of why would patients with PNH die prematurely. It would be mainly from the blood clotting problems. So other symptoms that are quite bothersome. So for example, many people have esophageal spasms. So basically sort of a pain in their esophagus, which is the food pipe that connects mouth to the stomach. And so basically as though sort of like food is stuck, and these sort of uncomfortable sensation. Other things are priapism, or basically male erectile dysfunction. And then of course, just association with low blood counts. So this classical PNH that occurs when patients have high disease activity, usually with a large PNH clone, needs to be treated to prevent some of these complications. So, and then also in thinking about this, so when do we start treating, and particularly, how do we evaluate the risk of blood clots in PNH? So a number of studies have looked at this in the past, and some of these factors that I'm listing here, we have compiled from multiple studies that looked at patients going back in different registries, including PNH, the International PNH Registry, and identifying factors such as the large PNH clone size, over 50%, that number LDH being about 1.5 times the upper bound of what is normal for the given laboratory. If people have a lot of symptoms, because symptoms are a real indicator of activity of PNH, of the red blood cell turnover. So dark urine, erectile dysfunction, abdominal pain, shortness of breath, chest pain, and of course, history can predict the future. If somebody clotted before, that's a really high, there's a very high likelihood that this will happen again. So what do we do for PNH? We now have, in the United States, we have 3 FDA approved drugs for PNH treatment. So the earliest and sort of the classical medication was eculizumab, Soliris. The second one that was approved was ravulizumab, brand name Ultomiris, and then the other one is pegcetacoplan or Empaveli. And I will use just the regular generic names from now on. So all of these drugs, the main mechanism, the way they work is by really attacking that complement. So they block those proteins that glob onto the red blood cells. And so the first two, eculizumab and ravulizumab, blocked this protein called C5, complement factor 5. And then the other one, the pegcetacoplan, blocks C3, which is another type of complement protein. And so there are some differences between them, but essentially they're all very effective at stopping the blood from breaking down. So some of the differences between, for example, the first two, eculizumab and ravulizumab, is in their half-life, meaning how often do you need to give it for it to be effective? So eculizumab is usually given every 2 weeks when it's in the maintenance phase. And then you may have a little bit of wiggle room of perhaps 1 or 2 days, but you really should stay on schedule to prevent the red cells from breaking apart. The ravulizumab was a longer version. So it's a longer version of the medication that can be given every 2 months. And usually it would be given intravenously. And recently there was a new announcement that a subcutaneous self-administered weekly version is also recently being approved. So finally, the newer drug, pegcetacoplan, which blocks a different complement molecule, was introduced, and it's more effective. In fact, that for some of the patients, it's significantly more effective than the other two medicines. So it really can elevate your hemoglobin, but there's some differences in how it's administered. So for example, for pegcetacoplan, it would be twice a week subcutaneous infusion that patient can give themselves at home. So anyway, so that is the basic overview of the medications that we give. The one really important risks of taking any of these medicines is the risk of infection. So if you remember when I mentioned that complement are the proteins that help our body fight off bacteria by globbing onto bacteria, poking holes in bacteria and letting it clear out. When we give these medicines, these proteins are no longer able to work. So it means that we really become at risk. This puts us at risk of insignificant infections, and particularly with different type of bacteria, such as meningitis, for instance. And so that is the reason why before taking these medicines, we really have to be sure to administer all of the prophylactic vaccinations. So meningitis vaccinations, also vaccinations for different types of other bacteria like pneumonia, like pneumococcus, and also Haemophilus influenza, which is another type of bacteria. If, for example, you're being started and there's a real urgency to get this medication started, sometimes we're able to prophylax with antibiotics. But that is really, again, a really, really important piece to not forget is how that you have to stay on top of the vaccinations and boosters, etc. So, okay, so we just talked about that example one. So that was an example of somebody who has a very large PNH clone, has a lot of symptoms, and was started on medication to treat PNH. Now, the second part of the second major presentation of patients who have PNH clones are somebody who has low blood counts and they have bone marrow failure or something called aplastic anemia, and they have a smaller clone, and they really do not have many symptoms from their PNH clone. So aplastic anemia has a very close relationship with PNH or development of PNH clones. And it's in fact the most common risk factor for developing PNH. What is aplastic anemia? It's another type of blood disease. It's an autoimmune, a rare autoimmune blood disease. And shown here is a schematic of what occurs in somebody with aplastic anemia. So here the stem cells are these red circles. And again, those stem cells are inside of our bone marrow. And we have another type of white blood cell, immune cell called lymphocyte. And here there is some problem such that the lymphocyte all of a sudden decides to turn on our body. And so it decides to attack for an unknown reason the stem cells in the bone marrow. And once that happens, the bone marrow essentially becomes wiped out of normal stem cells. And you can see a picture of what the bone marrow looks like with essentially just white open spaces. Those are so fat cells that fill out in that empty space of the bone marrow. And we see just very few those purple cells. So those would be the cells that produce blood. So essentially the bone marrow is wiped out. So what is the relationship of PNH to the bone marrow? Well, so now I'm going to shift again, and I apologize for using two different graphics, but bear with me. So in this graphic here, we have essentially the same picture as I just showed you on the leftmost triangle. Here we have those purple cells that were the stem cells, lymphocytes attacking the purple cell being in green. And we can see on top of the yellow cell that happened to have that mutation, and it's that PNH cell. So what is thought to happen is that these PNH cells, for an unknown reason, are immune. They are protected from this autoimmune attack, such that when the person recovers eventually from treatment, those cells are the last cells standing, so to speak, and we have this expansion of those cells, of the PNH cells. And so about 50% of patients with aplastic anemia have detectable PNH clones in their blood. So, and so essentially, because of this very close connection to aplastic anemia, if somebody comes with low blood counts and an empty bone marrow, and we detect a small PNH clone, this almost certainly would be a person who has an autoimmune attack in their bone marrow. So something like aplastic anemia or aplastic anemia. So it really is helpful from that perspective diagnostically. But patients with aplastic anemia generally do not have hemolysis, and they typically, again, there are always exceptions, but they typically would not need treatment with some of the drugs that I discussed. Okay, so we are coming towards the end, and I would like to finish with 3 more examples. Some of this may be a little bit technical, but I want to just highlight some of the other situations that are commonly, that come up, and some of the questions that have been asked in the past. So this would be an example again of somebody where we have aplastic anemia and the patient has a PNH clone, and we see that report that I just presented to you here in the box, and we see that the granulocyte are those neutrophils. So the person's clone size is 19%. And we see that in the red blood cells, there's a significant reduction in that clone because, of course, PNH cells lyse and you can't really capture them very well with the red blood cells. And so then we look at, and the question is this causing a problem? Does this need to be separately treated? When we look here on the other parameters, so in this patient's case, the hemoglobin is low at 4. The reticulocyte count, those baby blood cells, are also very low. So the baby blood cells are not being made, red blood cell is not being made. And the LDH at this point is elevated minimally, about 1.2 times the upper bound of what the test in the normal range is. So in this case, the way to interpret it is that the anemia, that very low hemoglobin, is really not due to the fact that the red blood cells are turning over rapidly, but it's because the bone marrow is not producing enough red blood cells. And so in this patient's case, this is a picture of aplastic anemia, and it's the aplastic anemia that should be treated first, of course, with the very close follow-up to make sure that this clone does not grow and does not cause problems in the future. If it does grow, then the treatment should be started for PNH. Okay, I'll move on to another example. So this is an example of somebody who is now in remission from aplastic anemia, has no symptoms, so doing very well. We have essentially a normal hemoglobin of 12. And then we look at those other parameters. The baby blood cells, reticulocytes, are normal. And the LDH, again, which is a marker of cell turnover, is also only slightly elevated. So there's no sign on these blood parameters that the red cells are turning over. Now we look at the PNH test report. And so here there's a little bit of a nuance where we look at the granulocytes, and the PNH clone size here is 38%, so it's quite hefty. And then we look at the red blood cells, and interestingly, we have this parameter that there is a difference between a partial deficiency, sort of a partial PNH cell that doesn't really break down as much, and the complete PNH cell. And in this patient's case, we have mainly this partial deficiency that appears to not lead to significant hemolysis. So this would be a very rare exception where a person may not need, again, there are always nuances here, but in general, this person may not need lifelong treatment with these complement blocking agents. Finally, this is my last example where I will highlight that some of these clones can be really, really small. And for example, you can see this was a patient who has very mild lowering of blood counts, and a PNH test is ordered. The PNH test shows very small numbers of PNH cells, so 0.01%, 0.02%, and all of the other markers are normal. So in this case, when the clone is so small, it's very important to repeat it. Sometimes these things can be transient, or whether they were real, or whether it was right at that lower end of what is detectable and what is considered noise. And so in this patient's case, for example, it was repeated, and these cells were no longer identified on the test report. So the significance of these very tiny clones is also unclear. Okay, so this was a lot of information. I will close with this summary slide. So today we talked about the detecting PNH cells. That's perhaps the biggest message of today's talk. Is not the same as diagnosing somebody with PNH disease. So, and it also does not mean that somebody needs to be treated for those PNH cells. So there's a complicated evaluation that is required once some PNH cells are identified. The biggest risk factor for developing these PNH clones is aplastic anemia. So somebody may have had aplastic anemia or should be evaluated for this immune-mediated bone marrow failure. There are two main presentations. So there's one presentation that's actually the most common, where somebody has this bone marrow failure or aplastic anemia and then develops a small PNH clone. Typically, patients would have smaller clones. They don't really have symptoms or significant hemolysis, and they generally do not benefit from starting these drugs, the complement inhibitors. But then there are other patients who have classical PNH. So in them, they have generally larger PNH clones, a lot of symptoms, and they're at risk of these deadly, terrible blood clots. And so in them, starting medication promptly after the vaccination is very important to prevent complications. So that is all I have for today. Thank you very much for listening, and I'm welcome any questions. Thank you.
Thank you so much for the wonderful presentation. And we do have a few questions. Our first question reads, do I still get the PNH symptoms of fatigue, abdominal pain, etc., if the drug treatment with Ultomiris is properly working?
So it's a great question. Typically, if the drug treatment with Ultomiris is working, you would have significantly fewer symptoms. So you would have fewer fatigue, your hemoglobin should be coming up nicely, you would have less shortness of breath, and certainly the abdominal pain should resolve. So those symptoms are a sign of something called intravascular hemolysis. So when these red blood cells break apart inside of our blood vessels, and they cause a lot of these spasms that lead to abdominal pain and contribute to the fatigue. So the answer is yes, if it's properly working, the symptoms should be significantly diminished or gone. I will add here that there are two possible exceptions to this. If the symptom was caused by something else, not PNH, it could remain. That's one thing to consider. The second part is that there's a small number of patients in whom we have this other type of hemolysis called extravascular hemolysis. It's usually about 10% of patients, maybe 15% of patients, where that is significant. In those patients, we do not see significant improvement or the expected improvement in hemoglobin. So for example, if somebody is coming in and they need transfusions with PNH, they get started on Ultomiris, all seems to be normal, except the hemoglobin is still very low, sometimes so low that they still need transfusions. Then it means that there's this likely other component, possibly due to this extravascular hemolysis. And for those patients, that other new drug would be better. And there are several other scenarios to also that we can consider, but generally, the bottom line is, yes, the symptoms should improve. If they didn't improve, then your hematologist would need to look at a number of other things to see, is it that the symptoms are caused by something else? Is it that you still have hemolysis and maybe you need this other medicine that that sort of addresses this other type of hemolysis, or maybe your red cells are not produced because of aplastic anemia, and so that may be the reason why there's anemia and more fatigue.
Thank you. This question is coming from a longtime PNH patient, and they found that there is a big discrepancy between the standard numbers used to gauge PNH severity and how the patient feels. They'd like to know, is there any research going on to improve a doctor's view of how a patient is doing?
It's a great, another great question. So the answer is yes. And there are several types of studies that are ongoing. Some of them are through the PNH registry, and some of them are as a part of these clinical trial follow-ups, where the community is looking at quality of life questionnaires. So basically questionnaires of different symptoms and sort of the symptom burden scores. So from that standpoint, yes, so we're qualitatively collecting information to, and some of these, some of this information is then fed into the big studies and recommendations, for example. So as in my answer to the previous question, where let's say you're started on treatment like Ultomiris, and you still have the symptoms, it may be that, for example, the hemoglobin has not sufficiently improved. So perhaps the hemoglobin is about 10 or 10.5, and you're sort of considered to be doing well, but yet you're still fatigued. And maybe it's this little boost in hemoglobin that we will hopefully have at some point soon with some of the newer medications.
Thank you so much. Our next question is it normal not to be treated if AA and PNH with 50% clone size? Is it beneficial to be tested annually for clone size? And will clone size decrease over the years?
This question really gets to the heart of when do we say that somebody needs to be treated for PNH, and the fact that while it would be nice to have one number for clone size at which we would start treatment, there are also other factors that come into play. Generally, so this is an answer that's going to be just very general and talk about the extremes that are clear cut. So if somebody has a clone size of 50% in their neutrophils, if their LDH is high, significantly high, let's say 2 times upper limit of normal, over 1.5 times upper limit of normal, and if the reticulocyte count is also high, and perhaps if there are symptoms, then generally, in most cases, that patient should be on complement inhibitor therapy. However, you can imagine another case. So for example, similar to the case 3 that I showed here, where let's say a PNH, let's say somebody has aplastic anemia and all of the blood counts are low, neutrophils are low, platelets are low, and you're in the middle of treatment for aplastic anemia, and there is this clone, maybe 50% even, let's say, but the reticulocyte count is so low that the bone marrow is essentially not making anything, then the focus for that patient should be on treating aplastic anemia, because the PNH is not really, there's nothing to turn over. The bone marrow is not working, right? And then the downside to starting the medication would be this immune suppression that you add on top of all of the other immunosuppressive medicines. Finally, there is that really, we call it in medical world, a zebra, that very unusual case. If somebody has a clone that I showed, I think it was my case number 4, where we have a clone that it's in number only, right? But that clone is a partial deficiency, and it essentially, the lab test is picking it up, but it's not causing significant red cell breakdown. So that would be really, really rare, right? So in most cases, if somebody has a clone of about 50%, and usually, unless there is this aplastic anemia that's active, usually those cells typically would be turning over, then I would typically recommend for a person like this to be treated with complement inhibitors. In aplastic anemia patients, generally, I always check in my patients at least annually, right? So if somebody never had a clone, I would still test them for a PNH clone, usually annually. Would it be that, let's say, they are 20 years out and the blood counts are normal? I don't know if we need to be checking at that point, but if they're closer to treatment, I certainly would be following it. And if somebody has a clone, that's particularly if the clone is relatively sizable, I may be checking it even more frequently than once a year, depending on symptoms.
Thank you. Our next question, it's a multi-part question. So the first part is it possible that a PNH clone needs the presence of aplastic anemia or another bone marrow failure disease to be active?
So, right. So it's an interesting question. I think, right, I'll try to make it simple. So the PNH clone, so that genetic mutation that happens, probably happens irregardless of aplastic anemia or bone marrow disease. It can happen in anyone at any point. But those cells by themselves, it's not a cancer. They don't have any growth advantage. They don't grow faster than normal cells. They are not superior than normal cells, except for whatever reason, if you have aplastic anemia or something very similar to that, where the normal cells are destroyed, whether it's the absence of some antenna on the cell surface or some particular surface protein or another protein that makes those cells survive better, right? So the cells were there, but for them to expand and grow to the point of what we call a clone, where it's above normal in the blood, that requires aplastic anemia, right? Or some other bone marrow failure. And some patients have MDS, for example, myelodysplastic syndrome or myeloproliferative neoplasms. They can also have PNH clones. But that, those cells that you have, they are active regardless of whether aplastic anemia is present. It's just the aplastic anemia pushes those cells to become a larger part of your blood supply, right?
Thank you. The next part of the question is, if the aplastic anemia is to be resolved, then would the PNH clone be crowded out by the healthy cells? If so, would the emphasis need to be made on resolving the underlying aplastic anemia, even if it is not severe aplastic anemia or another bone marrow failure when treating PNH?
So it's a very thoughtful question. So we have, right, so in some patients who they enter a complete remission from aplastic anemia, the cells that are present, even though they don't have a growth advantage anymore, they're also not, they're doing okay, right? So they are in this, right? I will distinguish here. So we have red blood cells that are in the blood that are being destroyed by complement, but they're produced by stem cells in the bone marrow, and the stem cells are happy and they're not destroyed by aplastic anemia or anything. So you can imagine when the normal cells grow out in the, when the person recovers from aplastic anemia. Let me get back to this picture, right? So in this picture on the left side, we have what happened before aplastic anemia. And the person just had, let's say, one cell that was a PNH cell with that mutation. Then aplastic anemia happens, lymphocytes destroy the purple stem cells, but aplastic anemia cells are in there and they are destroyed less efficiently, so they remain. Then, right, the person is treated, the blood cells recover, and what recovers was what was left over, right? And if PNH cells, stem cells were left over, once you recover, the clone actually can be large, or it can be 10% or 5% or 80%. So once you recover, those cells and people have followed what happens to PNH clones if they are small or big. Over time, it's sort of like a third. So a third stays the same, a third decline and sometimes become minuscule, and a third expand. And when they expand, it doesn't mean that they expand to when they need to be treated. They may expand to, say, from 0.2% to become 1.5%, right, or something like that. So, and then just to sum up then, it's unclear. So in any case, aplastic anemia has to be treated because that is the life-threatening problem. For PNH, we fortunately have very effective medication. So if PNH ends up developing later, we can treat it. It essentially is a disease for which we have now already have active, very nice therapy, and we will have even better therapy just coming down the pike. Aplastic anemia is much more difficult to deal with. So in general, aplastic anemia typically, if it's active, if it's severe, if the blood counts are low, it has to sort of take precedence in most cases.
Thank you. Our next question is there any tests that should be done regularly to detect blood clots?
So no, right, so the answer is no. We generally do not screen patients, for example, with like ultrasounds in their legs or MRIs or something like that to detect blood clots routinely. But if the person has a history of blood clots, for example, but they are already on treatment, so they are on effective PNH treatment, or in addition to that, some patients may be on a blood thinner if they had the misfortune of having a really bad, dangerous clot, for example, in the head or in the abdomen. So we typically would be doing it by symptoms, right? So if somebody has a swollen leg, then they would be screened for a clot, for example, in the leg, or if they have chest pain and shortness of breath that just came up suddenly, they would be looked at for a pulmonary embolism, or unusual bad headaches, for example, or stroke-like symptoms or abdominal pain, then they should be screened in those high-risk situations. But otherwise, once you are on effective complement blocking therapy, it's thought that your risk of blood clot is not higher than other patients. Right?
Thank you. We have 2 questions left. Our next question is, does PNH affect platelet counts? This patient's treatment has brought the hemoglobin and white blood cell back to normal, but the platelets remain low.
So the quick answer is no, not significantly. But the longer answer is that if you have an element of aplastic anemia and the stem cell either before, let's say if somebody had aplastic anemia, they were treated and the platelets never came up back to normal, right? In that case, the platelets would be low, even if one were to develop PNH and then get treated for it also. The other possibility that happens is that patients may, and this is just a hypothesis or just the way I and many in the field think about this, is that patients may have this autoimmune blood disease like aplastic anemia that occurred, blood counts were never low enough, and your bone marrow sort of rescued itself. And essentially, it's like you had an aplastic anemia that was mild, it got rescued, and now the bone marrow is not quite working normally. The platelets may also be low. So generally, in isolation, platelets would not be significantly reduced by PNH. Sometimes there's a little bit of maybe insignificant reduction in platelets due to PNH, or platelets may be somewhere in 100 or something like that range from PNH alone. So that would be right. You wouldn't expect significantly low platelets due to PNH.
Thank you. And our last question is, does extravascular hemolysis cause PNH symptoms similar to intravascular hemolysis?
So extravascular hemolysis, which for anybody else who is not as familiar with this, who is listening, so essentially this phenomenon happens when these complement proteins glob on to the red cells and they go through the spleen. So they break apart inside of the spleen, not inside of the blood vessels. And so with extravascular hemolysis alone, if somebody is already, let's say, on ravulizumab, for example, or eculizumab, the risk of clot is much less. So these patients generally are thought to be safe from blood clot. They also typically don't have symptoms like this erectile dysfunction or severe symptoms of esophageal spasm. So those happen because in the blood vessels, the blood cells lyse, and there's something called nitric oxide that it's causing spasm of different smooth muscles in different organs. So that is not also a concern. But if you have a low, for example, a low hemoglobin as a result of that, then, and for instance, if the hemoglobin is never came up to, let's say over 10, and so you're still with a low hemoglobin, there is fatigue. And to one of the people, sort of speaking to that question from the audience earlier about symptoms, so we need to do a better job of really annotating symptoms in patients who are on effective therapy, what we think is effective therapy, right, with the C5 blocking agents, and whose hemoglobin is let's say maybe below 10 or above 10, and who do have these extravascular hemolysis. So what are the other symptoms that I think perhaps we as hematologists may not appreciate as much, right? So extravascular hemolysis typically does not cause, nearly as many symptoms. So the one that probably remains is the fatigue and maybe shortness of breath, if this is due to just chronic anemia, right?
Well, thank you so much, Dr. Babushok, for sharing your time and your expertise with all of us today. If you have additional questions, you're welcome to send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit your question to our Facebook page. This webinar will be available on our website within 2 to 3 business days. On behalf of the Aplastic Anemia and MDS International Foundation, I'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our program. Thank you again. Have a great day.